Wonderful. Thank you so much. So it is my honor and my pleasure to bring to the podium Dr. Melissa Hardesty. I asked Dr. Hardesty to speak this morning to let us all know what clinical trials we actually have here available to all of you, and also what's sort of hot nationally right now. We really try very hard to have clinical trials available in every single disease site in both the upfront and the recurrent setting, and believe that it's critical to providing state-of-the-art care. I could not have a better partner than Dr. Hardesty. She is incredibly smart and has her finger on the pulse of what's new. And it sits on all sorts of different national research committees and travels to conferences, writes papers, and really is like having a mini medical center right here at Alaska Women's Cancer Care. So with that, here she is.
Well, thank you very much for that introduction. Okay, hopefully that's going to work. Yep. Okay, he's going to check the battery pack. While he's doing that, I want to say just a couple of things outside of my talk before I start. First of all, I want to welcome all the people that are participating by Zoom. This is the first year in 3 years, I think, that we're back live. And so it feels a little bit different because, you know, usually this room in the past had been totally full. And I just want to make everybody aware that there's more than 30 people Zooming in, including doctors from some of our partner communities. So welcome to the docs that I see logged in and to all the many patients. And I think it's really great that one of the good things that's come out of this pandemic is, increasing technology and access to really put these kinds of meetings and patient appointments and everything really more accessible, especially in Alaska. That's critically important. Anybody on the Zoom, if we didn't mention earlier, there's text Q&A. I'm the moderator for that. So if you ask a question during my talk, it's not going to get answered until after I get done. And then we'll have an open Q&A for all the speakers at the end of this talk, I believe. I really want to say that 2024 is a really exciting year for Alaska Women's Cancer Care. In many fronts, we are expanding our care delivery to other locations for the first time. So we're now going to Juneau, and that just started. And we're doing both chemotherapy and surgery in Juneau, and we're super excited about that. And I think that that's really going to be a wonderful service to be able to bring that care to people and to take the hassle of traveling out of the complexity that already exists with having a malignancy and having to get care and then having to be in hotels. And so we're extremely excited about that. We're partnering with the hospital down there and some of their practitioners to allow sort of seamless chemotherapy delivery, even if we may not be there when it's time for your chemo. We've got really great nurse practitioner and physician assistant on site that work with all kinds of oncology patients. And so we're really excited about that. We're really excited to welcome Dr. Pennington, who gave a fantastic talk. One of the biggest things that can be hard for us medical geeky doctor type people, which I am not one of, to know how to use language that's going to be able to be digested by the audience. And I think that she did a really fantastic job of speaking English to non-medically trained people. And so I want to applaud her, and I want to put a little pom-pom out and say that Providence participated in a big multi-center trial, really trying to figure out how could they do better as it related to genetic testing. And they basically came to us and said, what are you guys doing up there? Because you're testing everybody, and we want to do that too. So for those of you out there that are wondering, have I had this testing? The answer is yes. I can't think of a single ovarian cancer patient that has not had both germline and the other kind of testing, which we do there's multiple, these things are dollar values everywhere. And so there's multiple companies trying to help you decide to use their product to do these testing. And we've been consistent in how we've been doing our testing for a couple of years. And the particular product that we have decided to go with has sort of all of that on there. And that's why it works well for us, because we don't have to get this test then. It really just kind of gives us all of that information. And we'll talk a little bit more about that when I start talking about research. But we've really, personalized medicine is this sort of like thing that people have been talking about for years, and they go to meetings and they talk about personalized medicine, and then we were still doing the same thing for everybody. And I'm like, what, this isn't really personalized medicine. And I have to say that in the last 5 to 7 years, we are doing personalized medicine in a way that really never has been possible before. And it's amazing. And we're really moving the needle in many important ways. And I'll talk about some of that. In addition, sort of segueing into the research talk, Dr. Pennington has an extensive research interest, and most of her interests focus on, things that we can also look at up here. Any of you that have recently undergone cryotherapy or chemotherapy know that we're really big advocates of cryotherapy, which means when you get chemo, we try to make you put your hands and feet on freezing cold things, and that's to reduce neuropathy. And there's new research looking at whether or not doing that and squishing it at the same time, which might make it easier to keep the cold on. Like when you get cold and something hurts and you grab it and like squeeze on it, that might make you better able to tolerate the freezing therapy. And she's one of the national leaders on a big trial looking at that. She also runs the Living Well study. Some of you have heard of that. And if you haven't and you're interested, sometimes some of these things fall off of my to-do list when I'm running around a clinic like a maniac, but it's a really awesome study that is looking at initiating a wellness program post-treatment for first and second line ovarian cancer patients. It's an interactive platform. It's not a support group per se. It's more of wellness education and sort of all kinds of avenues for that. And so we're excited that she's going to be able to bring these projects with her, and we can hopefully expand access. So with that, let's talk about the clinical trial updates. Let's see. Oh, ooh, buzzes. Okay. So that's just my title slide. I don't think I actually put a disclosure slide. I am on, in addition to academic boards, a number of speaker panels and advisory boards for pharmaceutical companies. I'm not really going to be necessarily advocating for one or any treatment at the moment, so I don't think it's really a conflict of interest, but there is that. So clinical trials are really complicated and require many, many, many pieces to make happen. So this is sort of just an overview slide. Trials wouldn't be possible, obviously, without the patients who participate, but all the forces that really help us have trials open in Alaska. Our little practice by itself would not be able to offer clinical trials. It takes a tremendous infrastructure, a squadron of nurses, and it's really beyond the scope of this talk to get into the weeds about what's involved in getting a trial open, but it's complicated. And thankfully, we've partnered with Providence Alaska Medical Center, who has graciously allowed us to have access to their research department and all of the resources that go along with that. So the way that we bring trials to you is basically working through the Providence, research infrastructure. And so I really want to say thank you to that. And the way it works is there are different avenues for which trials can come to reality. They can come through pharmaceutical companies. They can come through what's called cooperative groups, which are non-pharmaceutical companies like academic institutions where people have new ideas about how to do treatment, or they can come, like I could decide I want to do a trial and I could write the trial now, but all of that stuff is very time consuming. So we wouldn't be able to offer that to our patients up here. And I'm the one that at the moment sort of drives the bus in terms of deciding what we're going to open and trying to, encourage sites to consider us. And I really focus right now on trying to bring novel therapeutics to the patients in Alaska. So there's many kinds of clinical trials, that we could do. And in an infinite world where I had just limitless research infrastructure, I would open hundreds of trials. But right now, just trying to make sure that the staff that we have is able to do all of the things that are necessary to open a trial. My goal is to try to bring new drugs to women who are getting limited on options or have less options for their cancer. Because the truth of the matter is, it's just not practical or pragmatic for most of our patients to go on a field trip to go on clinical trials. Unfortunately, most of the time you have to move there. They require multiple tests, multiple this, that, and the other, and people would be gone for months. And most of the time we're talking about patients that are dealing with recurrent cancer situations. And so the idea that they would go away from their home and their family and their life and all that they know and go live somewhere else is just not really doable for most people. So that's where I focus my attention. That said, there are some people where that is possible. And I do want to point out that, you know, if you have a cancer and you really want to get on a trial, or we're getting down to where I'm not sure what to do, that we always encourage you, to let us know that if that's something that you want to pursue. You can go on the NIH website and look for clinical trials. That can be really difficult to navigate as a patient. And I think the best thing to do, if that's the thing you want to do, is talk to your provider, let us know. And the most important thing is just kind of think about, like, where could I actually move? If you're just happen to be a multimillionaire, you can move anywhere, great. But maybe you have a sister that lives in Seattle, or, a family member that lives somewhere. And so maybe that would be more practical. And that helps us find a trial that is actually going to be doable for you. There's multiple kinds of trials. For therapeutic trials, they come in different phases. Phase 1 is basically trying to figure out what's the safe dose of a medication. A lot of people don't really understand that. Phase 2 and phase 3 is where we start getting into really trying to see what the benefit is, and that's where new agents come in. And then we're going to talk about what trials we have open in Alaska. So I'm going to focus this on sort of disease sites, and I'm going to try to kind of do it in a big sort of umbrella patient-centric way. So cervical cancer is thankfully a cancer that we see a little bit less of than we used to, and that's really thanks to prevention. Both primary and secondary, pap smears being secondary prevention, meaning finding precancers and taking them off. And then primary prevention is absolutely, without a doubt, the most important thing, which is vaccination. And so as the vaccinated age patients, they're starting to get old enough now where we're really going to start seeing less cervical cancer, and it's so exciting. Cervical cancer is an absolutely horrible disease. It's a disease that affects younger women. It's still totally rampant in resource-limited places that don't have access to vaccines. It's the #2 cancer killer worldwide of women, which is not something that people, I think, really realize in sort of the insulated United States, but it's a big problem. So when cervical cancer is not able to be treated initially with surgery, then it's treated with a combination of radiation and chemotherapy. And the most recent progresses in cervical cancer, and we don't have any trials open right now for cervical cancer. And part of the reason for that is, thankfully, we don't see as much cervical cancer as we used to. And many of these trials are conducted largely internationally because that's where the patient populations are. So that's why there, I think, are less trial offerings in the United States for cervical cancer. So I think there's been some really exciting advances in 2023 as it relates to cervical cancer. Some true practice-changing things have come out. There have been new FDA approvals and in ways that are even just recently presentations that are changing what we're actually doing with our cancer patients. And I'm going to go over just a couple of those trials very superficially. Really, the main sort of take-home 360 view as far as what's changing in cervical cancer in the last couple years. There's a hugely expanded role for the immunotherapy. This cancer is caused by a virus. The virus is a foreign entity, which means, our bodies are trying to get rid of that. It recognizes that it's not self. So it makes perfect sense that cervical cancer would be one of the cancers where immunotherapy really moves the needle. And so that's super exciting. And the thing about immunotherapy is it either works or it doesn't. But if it works, it's often what I will refer to as a home run, which is either a prolonged response or a cure. So for the patients where it works in a really a remarkable way that's very different from what we previously considered progress in other, in the past. We would be excited if we got people to live 3 months longer with a certain, drug that had a lot of toxicity. And that's where we are once cervical cancer, other things aren't working. And with immunotherapy, we are truly curing some of these patients. And it's really amazing because these are 30-something-year-old women with kids, and they're just a tragic cancer. There's a new drug that was approved last year. That's a thing called an antibody drug conjugate. So an antibody drug conjugate, and that's what I have that little cartoon there in the corner, is basically taking a drug that's really toxic or bad for you if you just infused it. If I just put it in your vein, it would cause all kinds of problems. And putting a little satellite dish on it that is targeted to something specific that maybe the cancer has a satellite dish. So, you know, our body is full of cells, and the way that our cells get things in and out of them is, you know, with these things called receptors on the outside of them, and certain cells have certain receptors. And the bottom line is, an antibody drug conjugate is a drug sort of hidden from your body in, you know, it doesn't become available to cause harm until it's taken into a cell. And so it's hooked up to something specific to the cancer cells or those kinds of cells. And so when it gets infused, it doesn't cause a bunch of harm. And then it kind of goes where the cancer is, gets in those cells, and really causes a problem. And that's sort of a very simplified way of explaining what an antibody drug conjugate is. But the idea is it's a nasty drug that will kill cancer cells that's protected your body. The rest of your body's protected from it by this antibody that directs it just to where it needs to go. So there's a lot less whole body toxicity. And this field is just completely blowing up right now. Meaning to say we're going to see tons of new approvals, and it's extremely exciting. So this is basically where where all the research attention is right now. And that one in the little parentheses there, which we refer to as TV, is the drug that was approved for recurrent cervical cancer. And that's the first approval in cervical cancer in some time. So it's really exciting, because basically once cervical cancer comes back, the treatment options for it were really to the point where I would tell people I actually wouldn't treat myself. I would just focus on my symptom management. And that's not a place that you know, we ever want to be. The other thing that's really come out lately is actually dialing back the aggression level for surgery for some of the early stage patients. So we're getting increasing data that tells us that if you've got certain amount of size of your tumor, that we might not need to do a radical hysterectomy, which is a more aggressive kind of a hysterectomy that has higher risk associated in terms of quality of life. It has terrible long-term risks with regard to your bladder function and leaking pee and a bunch of things that we don't want to do to you if we don't have to. And that's really exciting. So the big, I'm just going to put the title slide from these talks. This is just, these are the big things that were presented this year that are really changing what we're doing. And I put them here just so I know it's just helping me remember which trials to talk about. So the first one was this trial, and this was presented at the American Society of Clinical Oncology meeting in June of last year. And this was a big multi-center trial called the SHAPE trial. And essentially, this was the trial that looked at less aggressive surgery for early cervical cancer for properly selected patients. And they really showed that the outcomes were, it was safe to do it that way, and we could potentially still cure cervix cancer without compromising outcomes for women that have early cervix cancer. And this has changed what we're doing. We are literally doing something different now for women with early cervical cancers, and that's super exciting. The other really exciting papers were presented at the European version of ASCO, which is called ESMO, which is the European Society for Medical Oncology. And this was one of the really exciting trials looking at adding immunotherapy with chemo and radiation. And this trial is also changing what we're doing to the degree that it got FDA approval, which is the ultimate sort of stamp of you should be doing this. And basically, women that have stages 3 and 4 cervical cancer should have immunotherapy incorporated with their chemo and radiation. And we're starting to do that here, as are in other centers. And, you know, with any new development, there's always this lag period behind or between when the people who tell us what to do say you should be doing this, and when the people that pay for it go, we will pay for this. And I just want to nod my hat to my totally amazing research nurses and clinic staff nurses who basically know how to get blood out of a stone and will get these drugs for you, even if your insurance company hasn't completely caught up with it. So basically, Dr. Hope and I are totally spoiled. If we want something, our nurses make it happen. And that's thanks to their efforts. It's also thanks to a lot of the generous programs that a lot of these companies have that make these agents, that give us free drug and give us samples. And you know, I want to thank some of our pharmaceutical partners that are here today with booths outside, and their companies are providing free drug for our patients. These drugs are ludicrously expensive. You could have an opinion about that, but the trials are also ludicrously expensive to run. And so there's many ways in which the system could do better. And the fact that we're able to get free drug for many of our patients is really great. So this was a trial. So this is immunotherapy in a different way. This was an updated presentation. So when clinical trials are conducted, the first thing that we can find is something called PFS, which is progression-free survival, which means how long till the cancer comes back. That information is the first information that we can get from these kinds of trials. And then later on, we always want to know, well, are people actually living longer? Because that's obviously pretty important as well. So this was a basically updated presentation looking at the use of immunotherapy for people that show up with either recurrent disease or metastatic disease, where it's not just can be treated with radiation, where you have to do what's called systemic therapy or whole body therapy, because the cancer is in places all over the body. And basically what it showed is if you add immunotherapy to chemotherapy in those women, they're living longer. And this is, I mean, it's really, it's hard for me to really explain this to you guys as patients, but it's really a mic drop. These are the first times ever in recurrent metastatic disease where we're actually having people live longer. And that was an outcome which sounds obviously like what all we want, but really hasn't been observed previously. And it's unbelievable. So, we don't, unfortunately, not all the women, are cured. But if you look at that little tiny too small to see graph, you see the line goes down and then it kind of flattens out. And that's the thing that you see with immunotherapy, which is that like those patients, and then once they get to that point, they kind of usually stay on that line. So maybe we're curing 40 or 50% of those people with metastatic cervical cancer, which would be crazy compared to what the prognosis was before that. So it's really amazing stuff. And then another really big important trial was done called the Interlace trial. This trial looked at potentially giving a little bit of chemotherapy before doing chemotherapy and radiation. So just sort of changing the way we're sequencing things. And they also were able to show an improvement in overall survival. And so we've been also looking at incorporating that into our patients. So really exciting stuff that's actually changing our decision making. And I want you to know that, there's so much change. It's a full-time job. I'm very glad to have Dr. Pennington joining to help me with that job, because Dr. Hope is busy convincing everybody to give money to cure cancer, and that's extremely important. And I try to keep her up to date on like digesting all of this stuff so we can actually bring these things to you in Alaska. So I want you to know that we're really keeping our finger on the changes as they're happening. And then this is the trial that looked at that new agent, the antibody drug conjugate, which I'll here to refer as TV. And this was, again, a really important confirmatory trial. That drug got a preliminary FDA approval last year. And when they give a preliminary approval, it's because it's really exciting and it looks like it's going to be really helpful. But then they make the companies do bigger trials to show, no, is that really a helpful thing or not? And this was that trial, which did show that. And that's extremely exciting because, again, this is a disease site where once it's recurrent and failed standard therapies, the response rates for agents were less than 10%, and they're totally dismal, and they were very short response rates, and really something I mostly wouldn't do to people. So this gives us new options, and it's very exciting. So ovarian cancer, obviously, a thing that is probably of most interest to most of the people in this room. And actually, interestingly enough, ovarian cancer is one where historically we've had the most patients on chemotherapy and has up to this point been the cancer that's the trickiest to treat for gynecologic cancers. That if you look at amongst gynecologic cancers in the United States, which is the one that we're not doing the best on, it historically been ovarian cancer, because that unfortunately is usually diagnosed at stage 3 or 4. And I'm proud to tell you that not thanks to me, but I'm just happy to say that as of 2024, it's actually now behind endometrial cancer, which is not good on the endometrial cancer front, but we're doing so much better in ovarian cancer that it's actually come out of the first rank spot, which is amazing. So why is that? Some of that is due to risk reduction. This is the important stuff that Dr. Pennington was talking about, which is like if you have ovarian cancer and you go have or if you don't have ovarian cancer, excuse me, if you have fallopian tubes or ovaries, you have a high risk of getting cancer and you get those organs removed. That's helping it. But actually, interestingly enough, a lot of us actually think now that the thing that we've been calling ovarian cancer this whole time is actually a lot of it's fallopian tube cancer. And it turns out if you get your fallopian tubes out, you can really reduce your risk of ovarian cancer, even if you don't have a mutation. And so women out in the community are now having that done. If you get a hysterectomy because you have bad periods, OBGYNs are taking tubes out, and that's probably driving us seeing less ovarian cancer, which is like crazy exciting, because the best thing is just for it never to be diagnosed in the first place. Once you have it, then, we're looking at the best ways to treat it. We have some trials open, and I'll go over those. We have new approvals, and we have expanding maintenance options. So here we are again at the antibody drug conjugates, and that agent there in the little parentheses is mirtuximab, which is newly FDA approved for women that have that folic acid receptor. And actually, high is where the FDA approval is, but there's also another place where we get the how to do this as doctors, and that's called NCCN guidelines. And NCCN guidelines recently added that drug with another drug, which is bevacizumab, which is the anti-blood vessel agent, sometimes known as Avastin. That the two of those together can potentially make that agent also work in patients that are sort of intermediate folic acid receptors. And there's new antibody drug conjugates coming down the pipeline that are better heat-seeking missiles, and so potentially can allow this drug to work in people that are not just the 25% of people with the high expression. So that's really exciting. And then we're refining what's the best maintenance strategy. Those are things that, if you ask me what I suggest that we do for your cancer now, you asked me 2 years ago, you asked me 5 years ago, I'm going to give you a different answer, which can sound confusing, but that's because information keeps getting presented to help us understand the nuances of all these things more. So this is also similar to that other one I showed you. This is the confirmatory trial. We had this trial open in Alaska. So some of our patients were part of the publication for this. And this was basically the confirmatory trial that looked at that agent for recurrent ovarian cancer that's high, and showed an improvement in overall survival in what's called platinum-resistant ovarian cancer, which means that your cancer comes back within 6 months of being treated with platinum. That group of patients historically has been challenging for us to find drugs that work well. And this is the first time ever in the history of cancer research that an overall survival advantage was shown in a platinum-resistant ovarian cancer, which is, again, mic drop. It doesn't sound, like you would think, like, haven't we been showing that all along? But it's been a very difficult group of patients for us to show that if they get this drug, they actually live longer, which is ultimately, obviously, the most important outcome. So we have a couple of trials open in Alaska. One of the trials we have open is we refer to as the Acrivon trial. And I realize that slide's really small. Again, this is mostly just to remember which ones I'm talking about for you guys. The Acrivon trial is a trial that allows both ovary and endometrial. So you'll see the slide again when I talk about endometrial. This is a biomarker-driven trial. That means that we take a biopsy, and that'll break patients into two groups. They either have the biomarker or they don't. If they have the biomarker, then they get the drug by itself. If they don't have the biomarker, they get the drug with another agent that is intended to make that drug work better. So this is really exciting. This trial has very liberal enrollment criteria. They allow lots of prior lines of chemo, which is often a barrier to us putting people on trial. And so that's why I really pushed to open this trial here, because it's pretty easy for us to get patients to qualify for this. So this is definitely an option for women that have treatment-resistant uterus and ovary cancers. We have so the Artistry trial is open and then closed because it was completed accrual, which means they got all the patients on it that they wanted, and then they decided that they were going to have a few more patients to make this study a little bit more able to answer the question. So it hasn't reopened yet, but it will soon. This is a trial that was looking at trying to do combination immune therapy for ovarian cancer, immunotherapy. So right now, when I say immunotherapy, basically in 2024 in the United States, we're mostly talking about a thing called a PD-L1 or PD-L1 inhibitor, which is basically reactivates the immune system. Those drugs, unfortunately, have been disappointing all by themselves in ovarian cancer, but there is some reason to think that if you combine them with other kinds of immunotherapy, you might be able to do better. And that's what this trial is looking at. And we've had several patients on this trial. And when it reopens, we will certainly continue to be doing that. We have a trial looking at immunotherapy in first-line treatment in combination with standard chemo. And this is basically for neoadjuvant chemo patients. Neoadjuvant chemo means I might meet you as a new patient and decide we're going to do chemotherapy before we do surgery. So we do that about a third to 40% of the time, and it's a complicated decision. But when we decide that's the right way to go for you, then you could be eligible for this trial. And so that's exciting. And then we're in the final stages of the process of opening a trial, which is really a complicated, long process. This trial in particular has taken over a year to open. And this is looking at a new agent, which the category of which is called a WEE1 inhibitor. Lots of the earlier data has suggested that these are going to have good activity in ovarian cancer patients. And so very soon we're going to have this trial open as well. And this trial is important because it also looks at looking specifically at patients that have been on a PARP inhibitor before. And any of you that have gotten treated here in Alaska know that I am a very big proponent of PARP inhibitors in the first-line setting. And I can go over why that is, but I don't have time to do that right now. I think that if you're going to get a bang for your buck with a PARP inhibitor, you're going to get it in the front line. So we're very aggressive about frontline PARP, so which means almost everybody that recurs with ovarian cancer in Alaska has been on a PARP before. So having a trial specifically for those patients is very important, and that's what this is. And then this trial, I'm so excited. I just got an email that we are being offered this trial here. So this is Dr. Moore, who's in Oklahoma, who I had the pleasure of training with, and she is basically totally the steamroller for therapeutic clinical trials. She was on the SOLO-1 trial, that really exciting trial that you saw. Her name is everywhere, and she is just absolutely brilliant as it relates to clinical trial development. And some of you may know, like, we've sent patients to Oklahoma, and you'd be like, why am I going to Oklahoma? Why aren't I going to MD Anderson Cancer Center? Because Dr. Moore's in Oklahoma, and she's a rock star. And this it was a phase 1 trial that was presented at that European meeting. And I put it up here basically just because we're being selected as a site, but also if you could see the plot of how well this drug worked in a really heavily pretreated group of women. So phase 1 trials, again, how dangerous is this drug? What is the right dose? That's the objective of a phase 1 trial. You don't often see great responses. They have this thing called a waterfall plot, which is like this graph that shows how much shrinkage of everybody's tumor in a group of women that basically has heavily pretreated ovarian cancer with an average of 4 or 5 different prior lines of chemo. Almost everybody had either shrinkage or a response. It was a waterfall plot like I've never seen in platinum-resistant ovarian cancer. It's phenomenal. So I was very pushy about trying to get considered. And so I'm super, super duper excited that they selected us. A lot of butt kissing went into that. So uterus cancer is the last cancer that I mentioned. Unfortunately, we're failing in uterus cancer, and it's not so much that we're failing in treating it, we're failing in preventing it. Unfortunately, many uterus cancers are related to having extra weight. I have extra weight. I get it. The struggle is real. But unfortunately, the consequence of that is more uterus cancer in our country. Also, just as our population naturally gets a little bit older, we're seeing more uterus cancer. So those two things are driving the fact that the incidence, meaning how many people have uterus cancer, is going up, which sucks. So we need to do better. We need to focus more attention on this. I think the big developments in uterus cancer in the last year relate to the fact that this is no longer one disease. So we've always sort of called this one disease, which I say uterus, but the real part of the uterus that we're talking about here is the endometrium. You can get cancers in the other parts of the uterus. And the vast majority of what we see are endometrial cancers. And we used to say there was this thing called type 1 and type 2, which means the sort of ones driven by extra weight from extra estrogen, or there's the ones that are driven by just happenstance, live long enough, get mutations, get uterus cancer. But really, no, now we know there's really 4 groups of uterus cancer, and that's driven by a thing called molecular profiling. So they basically were really able to go away from what does the cells of this look like under the microscope to what is the biology of this cancer. And we're really doing so much better because now we're putting uterus cancer into sort of 4 different buckets. And I think that this is going to completely change how we think about uterus cancer and what treatments we recommend. So adding immune therapy, again, multiple huge papers. I'm going to show you this in a second for uterus cancer in the recurrent setting or the metastatic or spread setting that are really changing what we're doing every day in the clinic right now. Really understanding that breaking these groups into these 4 groups is critical for us really figuring out what the right things to do for people. And we have some trials as well. So these are the multiple publications. Both of them are actually published. And those are, I just put those up there to show how impactful this therapy is, specifically in the group of patients whose tumor has that little, what that little thing there is DMMR/MSI high, which basically just means when we do the testing to take people with uterus cancer and we break them into 4 buckets, there's one bucket where the tumor is a little bit more of a scrambled egg, and that is a kind of tumor that makes it easier for the immune system to see it. And so immune therapy works better for those women. Works better, crazy town better. And again, those lines like that, and previously in recurrent cancer settings, you see the lines, but they all are heading down, it's not working, down. And when you see the line go flat like that, those people could be cured. If they're not cured, they're exceptional responders. You look down on the bottom there, I can't see the unit, but there's like, that's years down there, which for a recurrent cancer trial is just not a thing that we saw before. So immune therapy in conjunction with standard chemo for recurrent cancer is curing some people. I think I might be overstating that, but I truly think that that's, if it's not a cure, it's an exceptional response that lasts for years, which is also very cool. So this is another one of the trials looking at adding not just immunotherapy, but also those PARP inhibitors that we have been talking about this whole time for ovary cancer. So there are some groups of patients that for uterus cancer probably benefit from that combination. We're still trying to understand exactly who those patients are, but that is also very exciting and is going to change the decision-making that we do in the clinic. I could have put this slide with any of them. And I don't expect you to understand all the nuances on the slide, except for to say that there's a thing called HER2, which is a biomarker. And it turns out if your tumor, whether it be cervix, uterus, or ovary, expresses that, we can attack that in particular. And lucky for us, and by lucky, I mean, there's way more research that happens in breast cancer in terms of dollars and people that get it, like probably 100 to 1 to gynecologic cancers, which is sucks, but it is the reality. And so a lot of how we learn to treat gynecologic cancers is sort of looking at breast because there's a lot of overlap. And it turns out there's really good data for this particular target, meaning HER2 in breast cancer, that has led to people looking at it in other cancers. And it turns out for the patients that have our gynecologic cancers that happen to have that molecular target, there are amazing antibody drug conjugates. Again, recurrent cervix cancer, recurrent uterus cancer, recurrent ovary cancer that have failed multiple lines prior had exceptional responses if they happen to be HER2. So you don't have to worry about it because if you've got one of these cancers, we know if you have a HER2 receptor or not. We are checking that. And if we see that, then we are definitely thinking about this agent, and the responses that we're seeing on this trial were really good. Oh, I didn't realize I got multiple there. Okay, so what do we have open? Here's that Acrivon trial again. So this trial is looking at that in both uterus and ovary cancer. So we have that trial. We have a trial called a Podium trial, which is very biomarker directed. So those scrambled egg tumors, whether they've had that PD-1 inhibitor drug before or not, can go on this trial. And then there's another target called FGFR. So when we're doing that special testing on your tumor, if it happens that you have one of these, then we can offer this trial as a therapeutic option. So very exciting. That same WEE1 drug also looks like it might work for certain kinds of uterus cancer called a uterine serous carcinoma, which unfortunately, while not the most common uterus cancer, is usually the one that we see where people have spread disease. And so it's a tricky one to manage. And we are planning to have that trial open, I hope, by the end of this month, actually, which is much effort has gone into opening that. So that's going to be a very exciting thing. And then we have a trial coming also that's a new antibody drug conjugate for recurrent uterus cancer that will hopefully be open by the summer, which probably means it'll be this fall. And we're really excited to have been selected for a site for that. And so basically, with that, I don't have no idea. I haven't been paying attention to my time at all. I talk really fast, so I probably should be good for 20 minutes. Oh, look, 10:43, perfect. I'm done. Okay, that's it. That's all I have to say. Thanks, everybody, and go get some coffee.